Good morning, everybody. We're going to get started with the next presentation. I'm Kirsten, your incoming president, and it's my honor to introduce Nicola Crich. She will be presenting on lung nodules. She's a physician assistant who currently works at thoracic surgery in the Department of London Health Sciences Centre in London, Ontario. She transitioned to thoracic surgery from her previous position at Hamilton Health Sciences in trauma and general surgery. During her time in thoracic surgery, she has found a new passion in cancer education and prevention. Nicola holds a Bachelor of Science from the University of Western and then went on to complete her Bachelor of Science PA degree at the University of Toronto. She one day aspires to share her passion and knowledge for healthcare within an academic role to further students' understanding and excitement, and to serve as a mentor and advocate for the physician assistant role. She is currently working towards publications in esophageal trauma and cancer. And during her free time, she likes to bake, golf, and spend time with her cats. Nicola?
Thank you. Okay. All right, thank you for that kind introduction. I apologize, I'm coming over a bit of a cold, so I may have a bit of a cough, so I will try my best to abstain from that. So again, hi, my name's Nicola. I'm obviously a physician assistant. I work in thoracic surgery in London, Ontario. And I'm just here to chat with you guys about lung nodules, a bit of the basics, red flags, and where and when you should refer these patients on. So I have no disclosures, just my general goals for my presentation to improve your knowledge and, oh, is it not working? Oh. Tech support. It's switching on here, but it's not going up on there. Oh, perfect. Okay, thank you. Okay, there we go. Okay, so I have no disclosures. This is just my general goals of the presentation to improve your knowledge and comfortability with our current lung screening guidelines, as well as improve your confidence when referring on to healthcare providers and, recommended follow-up for lung nodules. Improve your knowledge on red flags and suspicious lung nodules, and then clarify about who and when you should refer on. So mainly just respirology versus thoracic surgery. Just a general overview of what I'll be going over and the, I guess you could say, schedule. Okay, so cancer is obviously very prominent in our society today, and why am I here talking about lung cancer? So I grabbed this pie chart from the Canadian Cancer Society, and it breaks down the different percentages of cancer. And as you can see, lung and bronchial cancer takes up about 4.1% of all of the cancer in Canada. And although lung cancer only accounts for about 4.1% of all cancers, it accounts for up to 13% of newly diagnosed cancers, which equates roughly 30,000 Canadians, and this was from back in 2022. The caveat to this, though, is it doesn't include individuals that die before their diagnosis, that we simply follow along on their lung nodules, that we are very suspicious are cancer, but we either don't biopsy as the patient doesn't want that, or for a variety of reasons, and then also for individuals who do not want treatment moving forward, and therefore we don't confirm their diagnosis. Overall, the rates of lung cancer are declining, and this is since 2013, and this is mainly credited to decreased smoking rates in men and women in the early 1980s. That being said, though, despite declining rates of lung cancer accounts for about 1 in 4 cancer deaths yearly, and that was from 2022. So lung cancer in general, you break it down into your two general categories. So you have your small cell lung cancer. That accounts for about 10 to 15% of all of your lung cancer. Small cell lung cancer is a much more aggressive form of lung cancer than our non-small cell lung cancer. Oftentimes when you see it on imaging, your small cell lung cancer is going to be small peripheral lung nodules with very large, bulky hilar or mediastinal lymph nodes. So that's very telltale sign of small cell lung cancer. Small cell lung cancer is subsequently broken down into just staging. So you have your limited stage and your extensive stage. Limited means just in the chest, extensive means spread. Then you have your non-small cell lung cancer that has 3 subcategories: your adenocarcinoma, your squamous cell carcinoma, and your large cell type carcinoma. And then also these can be further broken down into different histological breakdowns, which I won't go into. Squamous cell carcinoma is very common in smokers, and these are often very centralized lung nodules. They're very large. And then you have your adenocarcinoma, which is your peripheral nodules. They're usually smaller, and these are very common or the more common type in non-smokers. So this is our general classification for staging for lung cancer. We first start with your T and an M stage, and this is our stepping stone to getting the classic stage 1 through stage 4 that you would normally hear about. So your T stands for tumor, your N stands for your lymph nodes and where they are relative to your body, and then M stands for your metastatic disease, so where it has spread. The chart on the right is just a breakdown of each individual subsection of the T and an M, and it's from the 8th edition of the International Association for the Study of Lung Cancer. I won't get too in detail about it. You can read over it later. We have it kind of taped up in our clinic, as there's no way that someone could memorize all this. But in general, when you move into your larger tumors, so your T3 tumors are going to be tumors of a certain size, of course, and as well as any tumor that starts to invade more locally. So invading any of your local structures, such as your pericardium, your phrenic nerve, and also it's going to be a lung cancer that you have 2 nodules in the same lobe, so histologically the same nodules. So that would mean in your right upper lobe, if you had 2 nodules that were both squamous cell carcinoma, that would be a T3. Whereas if you had 2 lung nodules in the same lobe, but one was an adenocarcinoma and one was a squamous cell carcinoma, each of those nodules will be staged individually. So those would be synchronous primary tumors. And then you step down into your T4 lung nodules, and those are going to be, again, nodules of a certain size, so above 7 centimeters, or a nodule that might not be 7 centimeters that have spread into the mediastinum, the diaphragm, and some of the vessels and nerves around that. And then that is going to be a lung nodule as well, that you have 2 nodules on the same lung, but in different lobes. So a right upper lobe nodule and a right middle lobe nodule. So we'd have to do like a bilobectomy on that individual if we were going to operate. And then in general, you have your nodes 0 through 3, and then you have your metastatic disease as well, which is your spread. And like what I like to say with your nodes is that as you increase in your node, so going from 0 to say 3, that's going to increase your stage. So your node involvement is really indicative of what your stage 1 through stage 4 is going to be. Okay. So then this is the actual classic stage 1 through stage 4. So on the right-hand side, you're going to see some photos that I grabbed from the London Health Sciences or LHSC's thoracic surgery website. And it's just a picture version of what each stage is going to look like. And then the chart on the right is from the International Association of the Study of Lung Cancer's 8th edition, and it breaks it down for your stages and puts your T and an M and the associated stage with that. So I'm not going to read all over it. It gets pretty complicated when you get into the middle stages, your stage 2B and your stage 3A and 3B. But in general, I'll touch on some of the more general principles. So you have your TIS, or your stage 0, which actually means a carcinoma in situ. These are very, very small tumors. They're very common in non-smokers, and they rarely spread, and they grow a little bit over time, but they're quite small. And then you can go into your stage 4, again, which is any sort of metastatic spread despite what size of the tumor is, okay? And then just to reiterate my further point about your lymph nodes, if you can kind of look at your stage 3A or even your stage 3B, you can see that as you go lower down your stages, it's really the jumping of the node size. Because if you look down on the tumor column, you can see how very sporadic it is. You can have a T1A, which is a very small tumor, be a stage 3, or it can also be a stage 1A, and that's really based on the lymph node spread. So looking at your stage 3B, you can see how most of it's N3 disease, and looking at your stage 3A, you'll see it's a lot of N2 disease as well. So lung cancer is obviously important, and that's why we screen for it in Canada in some of our provinces. So I'll quickly chat about our screening guidelines that we have. So Ontario and British Columbia are actually only the two provinces in Canada that do have screening guidelines for lung cancer. There are pilot programs that are going on in Alberta and Quebec currently. I'm not quite sure where they are at their pilot programs, but they are looking at the feasibility of having a screening program right now. I'm mainly going to speak about the Ontario guidelines. I practice in Ontario. A lot of our physician assistants are from Ontario. That's okay. But the guidelines between BC and Ontario are very similar. The only main difference is that there's going to be a bit of pack year difference for inclusion criteria. Okay. So in regards to the Ontario guidelines, there's going to be two studies that I chat about. You have two main studies, one called the Nelson study and one called the National Lung Screening Trial. So the National Lung Screening Trial is the trial that Ontario loosely bases our guidelines off of. And what this trial did is it looked at high-risk individuals, and by high risk I mean individuals between the ages of 55 and 74 with a 30-pack year history. These individuals were either active smokers or individuals who had quit smoking within 15 years. And what it did is it looked at a chest x-ray versus a low-dose CT scan with 2 annual repeats of the same imaging study. And they followed these individuals for a total of 3 years. And it found that there was a 20% reduction in lung cancer mortality at 6 years with a low-dose CT scan compared to a chest x-ray. And this was the first randomized control trial that actually did prove that lung cancer screening would help reduce lung cancer mortality. The Nelson study is from the Netherlands and Belgium, and it did something very similar. It was in 2015. It looked at men and women between the ages of 50 and 75, and individuals, again, who had a 15-pack year history, so a little bit lower, or who were either active smokers or individuals who quit within 10 years. So just a little bit of different inclusion criteria. And these individuals were randomized into no screening or screening. And individuals were screened with a low-dose CT scan of their chest at 1, 3, and 5.5 years. And to no one's surprise, it did show that their individuals who underwent screening had lower mortality rates than those who didn't, just proving that screening for lung cancer is effective and should be implemented. So then what are our guidelines for in Ontario? So it's a low-dose CT scan of the chest for individuals between the ages of 55 and 74. They have a 20-pack year history of smoking, and if they are active smokers, but if they quit, they had to quit within 15 years. They get an annual CT scan so they get their first CT scan, and then they get 2 subsequent CT scans yearly after that. The caveat to this is that you do have to be disease-free, so no other history of any sort of cancer. If they had colon cancer 15 years ago, they don't technically qualify for this. And again, it is pack years, so not actually number of years, but pack years. Okay, so you do your job, you're a physician assistant, you go back into your community, you're ordering your CT scans for your patients, and then your first patient comes back in, and she's a 72-year-old prior smoker. She quit 12 years ago. She does have a 30-pack year history, and she has no family history of lung cancer. The radiologist's conclusion is she has multiple 4 bilateral solid lung nodules in the right upper, middle, the left upper, and lower lobe. These were stable from 2019. And then there's a new 4 by 5 millimeter ground glass nodule in the left lower lobe. It has a small 1 millimeter subsolid component in this new nodule. There's no emphysema seen on the CT scan. They can't rule out infectious cause or malignancy, and clinical correlation is required. Then you have your second patient come in. Again, it's a 72-year-old gentleman. He was a prior smoker with a 30-pack year history. He quit 3 years ago. He does have a family history of lung cancer, and he was recently admitted to the hospital with COVID pneumonia. His conclusion says he has a single spiculated lung nodule in the right upper lobe. He has bilateral ground glass opacities, new from prior CT scan in March of 2023. Primary lung malignancy is not excluded. There's significant emphysema seen on his CT scan. Again, clinical correlation is required, and a referral to thoracic surgery or respirology can be considered. So a lot of information in these conclusions, not all of it helpful, some of it actually hindering your potential diagnosis. So just want you guys to keep those in mind for a little bit later in the presentation. Alrighty, so I'll go over just some of the signs and that you might see actually on the CT scan if you have a chance to look at the imaging. I'll talk about the red flags first. So things that you're going to see on the CT scan that would really kind of indicate that this is probably a malignant nodule or something that you would need to consider. I kind of went from most important or most common to a little bit more less important or less common that you're going to see. So on the left-hand side of your screen, you're going to see a CT scan with the nice little arrow sign towards a spiculated lung nodule. So spiculated means that you're going to have kind of a solid nodule in the middle, and then there's going to be these small little septations that are coming out from around it. It might be a little hard to see on the screen, so I apologize, but this is a very highly suspicious nodule. So anything that says spiculated is very suspicious for malignancy. And if a nodule is greater than 6 millimeters in size, again, very suspicious for a malignant nodule. The second photo in the middle, again, a lovely little arrow sign you can see pointing at the lung nodule, demonstrates what a subsolid nodule looks like. So what that means is you're going to have a solid component in the middle with a bit of haziness around on the outside of that. Again, very suspicious for malignancy. If the solid part of the nodule is greater than 6 millimeters in size, that increases the risk of malignancy significantly. And these lung nodules, again, very high risk. On your third and the last photo, it's a little hard to see because it's very faint, but where the arrow is pointing at, there's going to be something called a ground glass opacity. What a ground glass opacity is I like to explain it as just a haziness on the CT scan, or if you have a piece of glass and you step on it on the ground and it's all crumbly, that's what that's going to look like on the scan. Ground glass opacities are extremely common. You'll see them in inpatients, you'll see them in outpatients, and they're sometimes, a bit high risk, but other times they can be a bit lower risk. So oftentimes when you have multiple ground glass opacities scattered throughout both of the sides of the lungs, that's really indicative of more of an infectious cause of these lung nodules. What piques my interest for more of a malignant ground glass opacity is if you're going to have one single ground glass opacity in either of the lungs. That is very highly suspicious, as if it is infectious, as I was saying, you're often going to have multiple scattered throughout both lobes or even just one lobe. If the ground glass opacity is over 1 centimeter in size, that is also a risk factor for malignancy. So larger ground glass opacities are more indicative of malignancy. Since ground glass opacities are so common and are often infectious in nature, we like to follow these nodules a little bit closer for our first CT scan after. And oftentimes we'll order a CT scan at the 3-month mark for these individuals, as at the 3-month CT scan, if they are infectious, you should see some resolution at that point. There should be some significant changes on your CT scan if you have a ground glass nodule. Other risk factors that you'll see is just irregular borders in your nodule, so something that just looks a bit odd on your CT scan, it's probably a bit odd as well. So just keep that malignancy in mind when you see those nodules. Nodules, so on the first picture, you'll see where the arrow is. That's a ground glass opacity. There's maybe a little bit of a subsolid component in that, but mainly ground glass. And nodules in the upper lobe are an independent risk factor for malignancy. So if you see nodules in your right upper lobe or your left upper lobe, that's an independent risk factor for malignancy. Your middle photo is showing something called pleural tenting. So your pleura is obviously what lines each lobe of your lung. And what happens with pleural tenting is that the pleura will kind of pull towards the lung nodule. I don't see this very often in clinic, but it is something to note. And what that indicates is that this nodule has actually spread beyond the parenchyma of the lung and into the visceral lining. And if you do have visceral spread of the nodule, that would impact the staging of your nodule as well. And then lastly, the number of nodules. So the Nelson trial looked at the risk factor with malignancy and the actual number of nodules that a person has. And what it demonstrates is that your risk for malignancy increases when you go from 1 nodule to 4 nodules, but actually decreases when you go above 5 nodules. So 5 and more is actually reduces your risk of malignancy, whereas 1 to 4 nodules increases your risk of malignancy. Oftentimes when you have more than 5 lung nodules, that really points towards more of an infectious cause, whether that's a previous granulomatous disease, previous histoplasmosis, or something along the lines of a more recent COVID infection or just a pneumonia overall. Now, some more reassuring signs of what lung nodules are going to look like on your CT scan. So the first 2 photos kind of depict similar characteristics. So the first nodule shows more of a smooth triangular nodule. These are often intraparenchymal lymph nodes, and they don't need to be followed up. They often remain small. They may grow in size over time, but they're always going to remain relatively small, and they don't need to be followed up further. The second photo you're going to see is more rounded nodules. So any nodule that has very smooth borders, is very circular, that's reassuring. Oftentimes, this can be more along the lines of histoplasmosis, individuals who travel to Arizona very frequently, individuals that live in Northern Ontario, very high rates of histoplasmosis in those areas. So you'll oftentimes see these little tiny nodules kind of scattered throughout their lungs. And again, if they're nice and smooth, they're not really that worrisome. Again, the difficult part of this, though, is that as nodules increase in size, their features are going to become more distinguished. So very small nodules might look nice and round, but as they grow in size, then their features are going to become a bit more prominent. And like I said in the last slide, number of nodules is going to be an indication or a reassuring sign. That last photo there, very infectious picture, as you guys can probably tell. Lots of scattered lung nodules, some haziness of those as well, and those are a bit more reassuring for benign nodules or infectious nodules. Okay. And then this slide just indicates, again, you always need to consider your patient when looking at a CT scan or looking at a CT scan report. Your patient is the most important person in the room at all times, so always consider them when looking at their imaging. So some high-risk factors for cancer, as we all know, smoking. Smoking is the #1 cause of lung cancer amongst Canadians and around the world. So it's something that we need to take into consideration. On this note, there's still a lot of guilt and shame that smokers feel when they come into the office. Oftentimes, I've even heard patients who have deferred treatment, who don't want to have follow-up scans because they feel so guilty around the fact that they have this history of smoking. They feel like they deserve this diagnosis. There's even been multiple studies that have compared non-smokers and smokers to just generalized cancer diagnosis, not even lung cancer, and it's shown that these individuals who are smokers have a lot more shame, a lot more guilt around their diagnosis than, say, non-smokers, and there's still a huge stigma around this. So it's important as healthcare workers, support your patients, be empathetic towards them. I'm not saying treat them with kid gloves. They're adults. They know the consequences to their actions, but as healthcare providers, we don't need to add on to this stigma, and we don't need to kind of shame our patients moving forward. A personal history or a family history of cancer, again, a risk factor for malignancy. I had a 31-year-old patient who had lung cancer, and her mother passed away at 45 due to lung cancer. There is a smaller genetic component with lung cancer, so just keeping that in mind. Asbestos exposure, again, an independent risk factor for lung cancer, as well as mesothelioma. So mesothelioma is the cancer of the mesothelium. The mesothelium is the lining of our organs. When it's in our lungs, we call it our pleura. So these people will have a very high risk for having mesothelioma, which is unfortunately a non-surgical cancer and a very grim death. Emphysema, again, independent risk factor for malignancy, secondary to the chronic inflammation that you'll see with emphysema, as well as the tobacco use. And then, although not really a patient factor, doubling time of your lung nodules is very important. Infectious nodules often will have rapid doubling time, so you'll see changes at that 3-month mark. Very aggressive cancers like small cell lung cancer, again, will grow quickly, but it's more common that infectious will have changes, whether that's growing or resolving in close follow-up. And then always important, always compare to previous scans. So slower growing nodules at a 6-month scan or a 12-month scan where you see small, minute changes over time, those are more indicative of a malignant nodule compared to the rapid changes that you'll see with infection. The chart on the side just kind of summarizes what I chatted about. So I always like to back up what I say with facts, so you don't just have to believe me, but you can believe the data. So this study is conducted from April of 2004 to May of 2006. And what they did is they completed a regression analysis looking at the features of a lung nodule and the malignancy rate of that lung nodule. These are all the individuals from the Nelson trial that I touched on prior in the Netherlands and Belgium. And what they did is that they looked at 891 lung nodules in 658 participants. Of those lung nodules, 875 were benign, 16 were malignant. 68 nodules increased in size, and of those 68 nodules that increased in size, 10 of those were malignant. What the chart on the side, it just depicts the data from that regression analysis. So if you take a look at it quickly, you can even see, maybe I can put my cursor there, right here, when you look at spiculated, like I was talking about before, of the 69 nodules that were spiculated, 10 of those nodules were malignant, having a 14.5% of malignancy with those. And then if you look at our smooth lung nodules, 654 nodules had smooth, nice round borders. None of them were malignant. So that just kind of proves that, the actual, looking at the scan, you can really tell if something is malignant or not. So it's great to have intuition, it's great to have experience looking at scans and kind of know what you think something that looks like cancer, but having some quantitative data is really helpful. So these risk calculators, I'll touch briefly about these risk calculators. So the Brock University in Ontario looked at lung cancer risk, and they made this calculator that predicts your risk of malignancy over 6 years. It took into consideration the age of the patient, the nodule morphology, the location, sex, and family history. It's done via an Excel spreadsheet, so you just have to go on the Brock University website, or you can just Google it, and you can download them onto your computer. It's not very user-friendly, but UpToDate has a user-friendly version of the Brock University Lung Cancer Risk Calculator. It's the exact same thing. I screenshotted it and put it on the slide on the right there, and then you just punch in the numbers, and it'll tell you the risk that this nodule is cancerous over 6 years. So now if you just look back or remember back to the cases that I presented earlier, and they're here just to remind you what they looked like, I did the risk calculator for these lung nodules just to kind of help solidify some of the stuff I've been chatting about. Go to the next slide. If you can see it, it's a little small. But the first case, so that 72-year-old female, so I punched all of her data in. And the reason why I'm using that new lung nodule is, if you remember back, I said that she had 4 bilateral lung nodules that had been stable since 2019. So that shows that there's over 2 years of stability in those lung nodules. And that's reassuring that these nodules are benign. So I'm really focusing on the dominant nodule, which is that new 5 by 4 millimeter lung nodule. You punch in all the data, and it showed a 1.24% risk factor that this nodule is cancer. So the second case, I focused on that spiculated lung nodule, again, the dominant nodule. Those ground glass opacities that we saw, the bilateral ones, he recently had a COVID infection or COVID pneumonia. So very indicative that these are probably just infectious sequelae from his pneumonia. So looking at the spiculated nodule, I punched in all of his factors. He's male, he has a family history of lung cancer, he has emphysema. This was a solid nodule, it's in the upper lobe, and it's spiculated. And that nodule has a 34.67% risk of being malignant, so quite highly indicative that this is probably a malignant nodule. Just for fun, I punched in the ground glass opacities as well. I didn't screenshot it and put it on the chart here, but the ground glass opacities came back as less than 1% risk of being cancer. So these are the Fletcher guidelines. These are the holy grail of thoracic surgery and respirology. These are my saving grace in clinic and are really great. I have them pasted up on the wall so I can just reference back to them quickly. So what these guidelines are is they help us determine the interval in which we should follow up on lung nodules for. So these are wonderful in that they can just, if you just kind of follow along, you find where your nodule falls in it, it'll tell you what follow-up you should have with the nodule. These are evidence-based guidelines, and they do update them periodically. I think the most recent update was in 2018, if I'm remembering correctly. So the Fletcher guidelines, they're not intended for individuals who have a known primary lung cancer. So if your patient has a known breast cancer, a known lymphoma, these are technically not studied in that population. They are also not intended for individuals who are immunocompromised, so HIV, any sort of rheumatoid arthritis, those types of patients. These non-nodules don't really apply, these guidelines don't really apply to them. And any individuals under the age of 35, these were not studied in them. Individuals under the age of 35, the risk of infection is much higher than the risk of lung cancer is. So having serial CT scans is not in the best interest of those patients to reduce the radiation exposure. And decisions are really made on a case-by-case basis. So that 31-year-old patient who had lung cancer, the reason why we operate on that patient, the nodule was very small and not very concerning, but she had such a strong family history of lung cancer. Our guidelines would say no follow-up for that patient, but she had such a strong history, we did end up operating, and it was adenocarcinoma. So I put a little black box around the nodules that are really common. So the lung nodules under 6 millimeters in size and solid nodules between the 6 and 8 millimeters are very common. You'll see these a lot on incidental scans. Your patient got in a car accident, got pan scanned, and you have a couple of nodules. Now what the heck do I do with that? Patients that go in for an MI or shortness of breath and they get a scan for some reason, and then they always kind of defer to family physician and say family doctor will figure this out. So this is kind of very, very common that you're going to see. So I'll talk briefly about them. I won't go too much into it. You can all read this yourself, but I'll just kind of get into it a little bit generally. So any nodule that's under 6 millimeters in size, I'll first touch on solid nodules. So you have your solid nodules, you can have one single nodule or you can have multiple nodules. Regardless if you have one or you have 5, the risk that these lung nodules are malignant is less than 1%. So oftentimes these lung nodules don't need to be followed up on. So a lung nodule less than 6 millimeters in size, solid, 1 or more, often don't need follow-up. In the little red boxes on the side are for individuals who are very high risk. So active smokers, people who have high pack year history, a significant asbestos exposure. These individuals, you can get an optional scan at 12 months to just confirm stability. The optional scan is placed at 12 months because if you do any scans earlier than that, it oftentimes will show you stability, and that'll give you kind of false reassurance. So lung nodules that are less than 6 millimeters in size, within 1 year, they rarely upstage themselves. So, and by that I mean they rarely go from a stage 1 lung cancer to a stage 2 lung cancer. So following up at a 3-month mark or a 6-month mark is going to give your patients false sense of reassurance if this happens to be the 1% of individuals who get lung cancer from these nodules, or these nodules are cancerous. Now stepping down to your part solid nodules. So you have a part solid, so that solid part in the middle with the little ground glass around it. If it's one single lung nodule less than 6 millimeters in size, no follow-up. If you have multiple lung nodules, you can do a CT scan in 3 to 6 months. And then you can see there they added this CT scan at 2 and 4 years. So this was the newest addition to the guidelines, I think, again in 2018. And the reason why they added this is because in the Asian population, there's a 10% risk that these lung nodules will increase in size, and there's a 1% risk that these lung nodules will be malignant, and that's specifically for the Asian population. So that was a recent addition to the guidelines. And then we go down to your ground glass. Again, your solidary, less than 6 millimeter ground glass nodule, no follow-up required. If you're nervous, again, that 2 to 4 year CT scan, again, was added on for the Asian population with that 10% risk of increasing in size and the 1% risk of malignancy. And then if you have multiple ground glass lung nodules that are less than 6 millimeters in size, this is really indicative of infection. So that is why we have that 3 to 6 month CT scan, because at that 3-month mark, you're probably going to be seeing some changes, whether that's resolution or decrease in size of these lung nodules, or actually even cropping up of new ground glass opacities. And then again, that 2 to 4 year CT scan. So these are your 6 to 8 millimeter lung nodules. I'm just going to focus on your solid. As you get into the subsolid and ground glass, they become less common and are often requiring a bit more closer follow-up, require a biopsy, and I think it's very appropriate to refer on to respirology or thoracics at that point. Whereas the solid nodules can very much be managed in the community if you feel comfortable. So again, the same guidelines for multiple or singular solid 6 to 8 millimeter lung nodules. You'll get a CT scan in 6 to 12 months, and then in low risk individuals, so non-smokers, someone who maybe when they were a teen smoked for a couple of years, you can get another CT scan in 18 to 24 months. But then in individuals who are high risk, so again, those active smokers, large pack year history, family history of lung cancer, you would want to repeat a CT scan at 18 to 24 months. And then at 24 months, if those nodules are stable, you don't need to continue to follow them. If a lung nodule is stable after 2 years, that indicates it's most likely benign, and that's you don't need to continue to follow those. So what actually happens when our patient has lung cancer? So they'll come into our office, we'll talk to them for 45 minutes, we'll give them all this information, and then they leave utterly confused and look to their family doctor to explain the stuff all over again because they can't remember. So we have some common tests that we have. So you have your CT biopsy, your pulmonary functions test, and your PET scan. So I'll briefly just touch upon these ones. So your CT guided biopsy is kind of self-explanatory. You biopsy the lung nodule, you'll get some tissue diagnosis of it, but not all lung nodules can actually be biopsied. So if it's really deep into the lung tissue, it's not safe. If it's behind the spine, behind a rib, very close to any sort of vasculature or the heart, they can't be biopsied. But oftentimes, depending on wait time, sometimes we can't even get a CT guided biopsy for 2 months, which is a bit insane in the oncology world. But so oftentimes we might even just operate or do treatment without tissue diagnosis. Your second one is your pulmonary function test. So these are very important, not only for deciding whether or not we're going to operate on a patient, but determining whether or not how the patient will do post-operatively. So I know my respirology colleagues really care about all of the pulmonary function tests, but the ones that we kind of care about are going to be your DLCO, so your diffusion lung capacity, and your FEV1. So your DLCO is indicates how well your lungs function or how well your lungs can perfuse oxygen, and you will get a percentage from 0 to over 100. Our soft cutoff for surgery is in and around 40% for a DLCO, because when we're removing a lung, each lung has its own percentage that it contributes to the overall capacity of your lung. I'll talk a bit more about that when I get into SPECT scan, but in general, if I'm taking out, or if the surgeon is taking out your left upper lobe, that's taking away 30% of your lung capacity. So if your lungs are only functioning at 40% and we're taking away a lobe that contributes upwards of 30%, probably closer to 10% if you think about the capacity of it, your lung function is going to plummet and you're probably going to be on home oxygen. So we really care about the DLCO. And then we have your FEV1, so your forced expiratory capacity in 1 second. And it's not as important as your DLCO, but it's more of like a supporting test for it. So if someone has a borderline DLCO, 50, 55%, and I look at their FEV1 and their FEV1 is 52%, that kind of shows us more that they probably aren't going to tolerate this. 1, their lungs don't function very well, and 2, they don't have that capacity to inhale and exhale to the strength that an individual with a higher FEV1 would have. So they kind of work together. A PET scan, again, is done for most patients. Not all centers have it. LHSC does, and the big surgical centers will. But what a PET scan is, it's a nuclear medicine scan. We inject a radioactive glucose tracer into the patients. We wait 2 hours, and then we scan them head to toe. And what it does is that it looks for metastatic disease throughout the body, as well as looking at the uptake of the lung nodules we're looking at. So if a lung nodule is highly suspicious, it will glow on the PET scan, like in that upper picture you see there. It'll be nice and bright. It'll look yellow, orange, red. And that can kind of help us determine whether or not a lung nodule is malignant. Excuse me. But it's more important for checking for malignant disease elsewhere. And then, like I was saying, PET scans are actually really helpful if patients have multiple lung nodules and we can't really determine, or by just looking at them, and you can't biopsy the nodule, whether or not the nodule is PET positive. Because if that nodule is very, very PET positive, it kind of pushes us to work more, this is more of a malignancy. And if they have multiple nodules and a couple of them are suspicious, it'll help us indicate what one's the best to biopsy. Because even though the nodule might be the most peripheral and the easiest to biopsy, if it doesn't light up on PET scan, there's no point in biopsying that because it's not going to give us the data we want. So not only is it great for diagnosis, but it can really help in determining which one to biopsy. Just for patient information, for a PET scan, you need to be NPO. For diabetic patients, we allow it for about 4 hours. For non-diabetic patients, it's 8 hours. And if your patient's getting an inpatient PET scan, they can't have any glucose or dextrose in their IV. I made that mistake once and I'll never forget. So your patients can't have any glucose in their IV, and they can't take their metformin. Metformin will make the bowels light up, so it will negate the test. Then more of our optional tests, you have your MRI of your head. Again, check for metastatic disease. PET scans aren't great for the brain. Your brain always lights up, it's always active, so we like to get an MRI of the head. It's indicated in the literature for any lung nodules that are centralized, any lung nodules that are over 3 centimeters in size, and nodules that, if a patient is symptomatic. So new onset confusion, blurry vision, personality changes, that indicates a PET scan, an MRI of the head. Next, you'll see there is something called staging the mediastinum. So what that means is we bring them to endo, I put a bronchoscopy tube down them, I put an endoscopy tube down them, and we ultrasound the actual mediastinum, so the center part of the chest. What that's looking for is enlarged lymph nodes, invasion into the trachea for the tumor, or invasion into the esophagus for the tumor. This is done for lung nodules that are centralized and any lung nodule above 3 centimeters. So similar indication for your MRI. And then that SPECT scan that I briefly mentioned prior. So a SPECT scan is a specific type of CT scan or a perfusion scan that looks at the percentage that each lung nodule contributes to overall lung function. So you can have general percentages that your lung lobes are going to contribute. Like your right middle lobe usually contributes about 12% of your overall lung function, and your left lower lobe usually contributes 30 to 35% of your overall lung function. So we do that just to kind of, if we need to take out, say, the right upper lobe, it can kind of show us what percentage that patient will lose, and we usually do it for patients that have borderline PFTs. It's not a very common test. And your gallium scan or your dotatate PET scan is just for carcinoid tumors. No other tumors like an adeno or a squamous, it's just your carcinoid, and that's the only thing it's approved for. And then your bone scan, picture on the very bottom there, that's just if we're worried that there's bony mets in patients. So what treatment options do we have for our patients that have lung cancer? So we have radiation, chemo, immuno, and surgery. So radiation, it's stereotactic. It is very local and very contained to the area. Patients tolerate it really well. Radiologists sometimes need a tissue biopsy for this, but if you can't get a biopsy, then you can sometimes still send them to radiation for treatment. It's about 70 to 80% effective, and it's really great for people who, in their elderly patients that won't tolerate surgery, patients that don't want surgery, and it's very well tolerated. There's still going to be some side effects to it, but it's overall pretty good. Chemotherapy is only for metastatic disease, or if in the post-op period when we get our pathology report back, they have lymph nodes that are positive. About 30% of our patients actually get upstaged when they go from workup to actual surgery, and by that I mean we go in there, they're on their PET scan, none of the lung nodules lit up. We do the surgery, we take out the lymph nodes, and they became positive. So lymph nodes on PET didn't light up, but in the surgery after, they are positive for cancer. So they need to go to chemotherapy. And immunotherapy. This is the new kid on the block, and I'm really excited about it because it's showing great effects. So what it is we'll use often nivolumab. You take it for about a year, give or take. And the Checkmate 816 trial is the cornerstone for immunotherapy. It randomized patients from stage 1B to 3A resectable non-small cell lung cancer to either receive chemotherapy and nivolumab or immunotherapy, or just chemotherapy alone followed by resection. So previous standard of care was just chemotherapy, and what they did is they just added on immunotherapy to that. And the primary endpoints were event-free survival and pathological complete response post-operatively. And what it showed was that in chemo and immuno, the median event-free survival was 31.6 months, so 2.5 years-ish. And then chemotherapy alone was 20.8 months. So adding on immunotherapy gave them a little over 11 months more survival than just chemotherapy alone. Pathological complete response with nivolumab and chemotherapy showed 24%. So 24% of patients after their resection had 0 viable tumor left when we took out their lobe wedge, whatever we did. With chemotherapy alone, that was only 2.2%. So it showed that adding on immunotherapy preoperatively increased your survival rate and also increased the response and the pathological response to it as well. And it did not actually impede the feasibility for surgery. Nivolumab just got approved by the FDA in 2022 in March, so we're really just starting to see these patients now. I've seen about 3 or 4, and it's pretty remarkable, the results actually. And lastly, surgery, so my favorite. So oftentimes we'll only really operate on N0 to maybe N1 disease. We might see this now changing with immunotherapy because we'll restage them after they have the immunotherapy, and if they went from like a T3 N2 down to a T3 N0, then we could potentially operate on them for that. We rarely operate on metastatic disease, and we rarely operate on tumors larger than T3, so larger than 4 centimeters. That being said, we had a 91-year-old a couple of months ago who had a 7-centimeter tumor that we took out, and he did well. Surgery is about 80 to 90% effective, and people always, again, is there an age cutoff for surgery? Not really, it's more of your functionality. Again, we operated on a 95-year-old, I've seen a 96-year-old be operated on, and I've seen a 44-year-old be turned away. So it doesn't really, age is not really a factor anymore. So when do you want to refer your patients on? So you have your patients in clinic, they're getting multiple CT scans, and if you see any significant growth in that lung nodule, significant growth is 2 millimeters or more, or consistent growth over multiple scans. So you get a scan at a year, and then it grows by 1 millimeter, and then your scan at 6 months shows another millimeter of growth. That's enough that you should refer on. Or if you look at the Fletcher guidelines and there's any sort of escalation in care, you need a biopsy, you need closer follow-up than previously, or you have a new lung nodule, then that should probably be referred on. And it's really important to discuss goals of care when referring on your patients. Do your patients want to be followed? Do they want surgery? Do they even care that they have lung cancer? So that's really important because we do need to see these patients within 1 to 2 weeks of a referral. That's what the Ontario government has said. So if you refer a patient onto thoracics or respirology, we, by guidelines or by our documentation, we're supposed to see them within 1 to 2 weeks. And who should you refer to? Thoracic surgery versus respirology. We both deal with lung nodules, and we often refer to each other. Again, like I said, Ontario guidelines, we're supposed to see patients within 1 to 2 weeks. And this is more towards Ontario-based physician assistants or physicians. There's something called your diagnostic assessment program. It's really great. It's by Cancer Care Ontario, and what it is you fill out the form on the side here. It's for many different hospitals throughout all of Ontario. And what it does is those forms get filled out, it gets sent to a centralized documentation or booking office. And then we have nurses that then triage that out and will refer on to the surgeon or the respirologist with the lowest wait time. So it helps equal out wait times throughout all of the services. And it's great because then you don't have to know who you, like a surgeon that you're referring to. You can just send this off and they'll send it to the most appropriate one or the most appropriate respirologist. And this is not just for lung nodules or lung cancer. There's some for colorectal cancer, there's some for pancreatic cancer, there's colonoscopies that you can do this this through breast cancer, thyroid cancer. So it's really, really great for just not even just what I'm chatting about today. And we highly encourage using this program to refer on. So now your patient had lung cancer, we took it out, and we don't just say bye after surgery, we like to follow them. We follow them for a full 5 years. These are our Cancer Care Ontario guidelines. So for the first 2 years, we follow them with a CT scan every 6 months, and from 3, 4, and 5 years, we do annual CT scans. Some of the more seasoned thoracic surgeons who may have been trained 35 years ago will do x-rays rather than CT scans, but the guidelines today do say CT scans. And like I said, we often say this is a non-cancer patient, and we get referred for a lung nodule. We often will follow for 2 years with, and if it shows stability at the 2 years, then we'll discharge them back to their family physician or family nurse practitioner, physician assistant. So this is a really ugly slide. It's a very data dense slide, but this is just talking about survival in lung cancer. So I don't want you to get too caught up in the numbers, but this is a really important slide, and I like to take some time with it. So the first chart you're going to see on the left-hand side, again, that's just the T and an M staging and correlating with the actual stage 1 through stage 4, again, from the 8th edition. The graph below it, so that's labeled A, is from the 7th edition of the International Association for the Study of Lung Cancer, and it looks at survival curves. The graph B is from the 8th edition of the International Association of Lung Screening or Study of Lung Cancer, and again, it depicts the same thing, the survival curves. So looking at the first graph, you can see that in between the lines, or even if you look at the data at the lines below it, you'll see that there's a big gap in between all of the lines. And the people who wrote the paper also noticed that. So what they did was they did a regression analysis, and they looked at histological or pathological stage and survival rates. And what they noted was that there was a really big difference between each stage. So if you go from a stage 1A to a stage 1B at 24 months, survival goes from 93 to 85. That's a pretty big jump for just jumping one small stage. So that's why they came up with the 8th edition. So with the 8th edition, they just broke it down even more based on the histological pathology of it, and they were able to do a bit different staging, so it showed a lot better or more reliable data. So if you go from a 1A1, you have a 97% survival rate at 24 months, and then you go to a 1A2, it only drops down to 94%. So it just gave more accurate data for our patients as well as for us. So now actually looking at the survival rates for lung cancer, they have significantly improved over 10 years. Keep in mind, this data is from 2018 as well, or 2020 on the right-hand side. So that doesn't include the recent immunotherapy gains in lung cancer. So this data might be null and void in about 3 years when we restudy it with immunotherapy. But looking at it for a very early stage, so a stage 1, a T1A N0M0 has a 92% survival rate at 5 years. And even a T2B is a tumor that's 4 centimeters and above. So a pretty big tumor. At 5 years, that's still a 60% survival rate, which is pretty good. Another big takeaway that I like to say is that when your nodes become positive, your survival rate significantly drops. So a T1A N0M0 has a 92% survival rate, but a T1A N1M0, the survival rate drops to 50%. So it almost cuts your survival rate in half if you have nodes positive. So that really shows that we need to be screening our patients with our screening CT scans. We need to be following up and referring these patients on, because even just adding a lymph node that's positive, their survival rate drops in half. So that's just a bit more indication to screen your patients. And then a little bit about our stage 4 lung cancer. So stage 4 lung cancer used to be a death sentence. You used to have weeks to months to live. Now that data is extraordinary and showing that we can even give patients up to 5 years with survival with stage 4 lung cancer, which is amazing. So So 5 to 10 years ago, again, weeks to months. Now, if you look at that dark green line on the second graph, I know it's hard to see, at the 2-year mark with the dark green line, you have a 23% survival rate, and at the 5-year mark, you have a 10% survival rate without immunotherapy. So this is just chemotherapy. Now we add on immunotherapy to the ball game, and it showed, we have 2 studies that I like to talk about. So you have your Keynote 189 study, and you have your Keynote 024 study. So the Keynote 189 looked at chemotherapy and immunotherapy, and what it showed is that the overall survival rate for these individuals with stage 4 lung cancer who got chemotherapy and immunotherapy, the survival rate average was 22 months, so much better than the data you're seeing here, and it reduced the risk of death by 44%. So that's almost like 2 years that we're giving our average patient with stage 4 lung cancer with immunotherapy and chemotherapy. That's a lot for some patients who 5 years ago, 10 years ago would have had weeks to months. Now, if we even go even more into immunotherapy, looking at it added on with a certain tumor marker called your PD-L1, your survival rate at 5 years, if you are PD-L1 positive, you get immunotherapy and chemotherapy, jumps up to 31.6%. So 31.6% of people with stage 4 lung cancer that are PD-L1 positive, at 5 years, there's 31% survival rate, which is unheard of and absolutely phenomenal. So just, if you have a stage 4 lung cancer, refer on. We have treatment options for them, and we can even give them years to live. Just some key points that you can read over, my references, so you know that I'm not just making all this up. And that's about it. So I appreciate your time, guys. Yeah. I know we don't have a lot of time for questions or anything, so I'm happy to chat after. I won't take up any of the next speaker's time.